Okay. Well, good morning, everyone, or good afternoon, good evening, whatever time zone you're in. A real pleasure to be part of this. Wish we were in person, but hopefully in the coming months, we'll be able to meet as a group again. Today, I'm going to discuss ACL injury and the biomechanics associated with ACL injury. And can we do anything from a biomechanical intervention perspective to mitigate risk? I am a consultant for Major League Soccer for their MMARC Medical Assessment Research Committee. So we know the ACL injury rate is quite high, and it continues to be high. So in our high school aged cohort, which is basically our 13 to 18-year-old girls within the United States, girls soccer leads the charge with respect to ACL injuries, closely followed by boys soccer. In the United States, we have about 187,000 injuries per year in this particular cohort, 43,000 of which are ACL related, which is pretty astounding. If we look at ACL injury rates in the collegiate cohort, which is the next oldest cohort that we were examining from a research perspective, and those are individuals between the ages of 18 to 25. There was a good study done looking at a 5-year longitudinal period with respect to NCAA data, and the injury rate in women exceeds that of males by about 3 times. And what's stunning about this is when we follow these individuals out longitudinally, within 7 years, 65% of them are no longer participating in the sport. This is a fairly recent photo of our women's national team. And what's fascinating about this, 64% of our starting 11 for this particular match had at least one ACL, and 2 members of this particular group had more than 2 ACL injuries. So we know they're happening with incredible frequency. Even despite our most earnest efforts to prevent these, we still have a massive issue with respect to incidence. There was a study reported back in 2016. Walden and Hagelin looked at ACL injuries in professional football, looking at a 15-year prospective study and looking at the trends with respect to those athletes that successfully returned to play. So they followed 78 teams over 15 seasons, and they found that the initial return to play rate was quite high. 97% of these individuals returned to play. 7% were re-injured during training for actual preparation to return to play. But after 3 years of watching these individuals longitudinally, only 65% of them were still playing. So Amy Arundel and I followed up a similar study. We did this in our domestic league and Major League Soccer, and we looked at 71 ACL injuries over 3 seasons. We compared those individuals to age and skilled matched controlled within the same league. And we found those individuals that had successfully returned back from an ACL, there was a significant difference in how they were participating in the group. So a significant percentage of them weren't starting any longer. They were used more as substitutes or being unsubbed. And what's interesting is their career length was significantly shorter. So those individuals that had come back from an ACL, their career length only was about 1.5 years following their ACL injury, compared to the individuals who were uninjured, which was nearly double. So when we think about ACL injury, there are 4 steps to reduce injury, and we're going to discuss those. First one being the mechanism of injury. So we need to identify prior risk factors, and we can use video analysis, either of the individual or of team, to look for footage to see if we can identify any risk. So there have been 3 really good analysis studies that have been published. One more recently, one we had published a few years back, looking at risk factors associated with ACL. And we found that 73% of the time it involves some sort of defensive maneuver, not a defender per se, but an athlete working in a defensive capacity. 51% of the time it was tackling, 15% was cutting. Marcus Walden followed up a study looking at a video analysis as well, and they found very similar results to us. 44% of the time there was a defensive move in play, 20% was landing after a heading, 24% was direct contact with the leg or knee. A more recent study by Francesco Della Via, they found that there was indirect contact was relatively equal to non-contact injury, which was a different finding from the prior two studies. But again, very similar to the two studies that we just mentioned, pressing, tackling, being tackled, all of these ACLs were sort of predictive in that regard, looking at this defensive type play. They interestingly had more ACL injuries in the first half of play. We did not find that finding in our particular study. So the second step to mitigate risk is to look at the surgical intervention and the primary prevention, and then ultimately secondary prevention. So there have been many ACL injury programs that have been scientifically vetted throughout the years, two of which I was involved with developing, but there have been so many good researchers that have dedicated their careers over the last 2 to 3 decades looking at ways to not only mitigate risk, but ultimately, hopefully, prevent injury, the primary injury. The first study I'd like to discuss is the Pep program. So this was designed back in 2000, and it was a neuromuscular training program on the field, very similar in design to the 11 plus. This was designed primarily to address the high rate of ACL injury in female athletes. So we did this study in Southern California. This was a large study. There was nearly 8,000 people in the study, and we looked at primary ACL injuries in female club soccer players between the ages of 14 and 18. In that particular study, we had really fantastic results. In the first year of the study, we did a 2-year longitudinal randomized control trial here. We had an 88% reduction in the first year for those individuals utilizing the Pep program compared to the intervention. They were just using their usual warm-up program. So we were actually quite astounded, to be honest, about the results. So we continued the study for a second year, and we had very similar findings. Those individuals utilizing the Pep program, there was a 74% reduction in non-contact ACL injury compared to the intervention group. The following year, we collaborated with the Centers for Disease Control in Atlanta, and we brought this program to an older cohort, so the NCAA. So these are individuals between the ages of 18 and 25. We had 61 teams involved in this particular study, and we had very similar results to what we found in the younger cohort, the high school age cohort. So we had an overall 72% reduction of non-contact ACL injury when we looked at practice and games. So if you look to the lower portion of this chart, and a 45% reduction when we included practices and games. When we looked at practices alone, there was a 100% reduction in ACL injury. There was also a 100% reduction in those individuals in the late in season. So in other words, when we bifurcated the season into 2 halves. When we looked at weeks 7 through 14, we had no ACL injuries in practice or and a training session, in practice or games rather. So a 100% reduction. And what's interesting, we look at the top of the graph, the history of ACL injury. So those individuals that had come into the NCAA with a prior ACL injury, we only had 1 reoccurrence, and it was a contact injury. So there was an 80% reduction in contact reoccurrence and a 100% reduction in non-contact reoccurrence. So we know there's been numerous attempts to decrease sports-related injury, primarily focused on ACL injury. However, other deleterious injuries remain, and we know that they're exceedingly common in the sport of soccer or football. So was there an intervention to address all of these soccer-related injuries, not only specific to ACL? So that led to the development of the 11 plus. And the biomechanical goals of the 11 plus were to increase hip and knee inflection, decrease hip internal rotation, knee valgus and abduction, decrease vertical ground reaction forces during landing, just to implement this proper landing technique that has been ubiquitous throughout the other prevention programs that we've discussed earlier. So this study was run in Oslo. Solidguard was the primary investigator on this, and they did a large RCT in Norwegian female soccer. There were nearly 1,900 females involved between the ages of 13 to 17. There was a 32% reduction in all injury by those individuals utilizing the 11 plus program, and a 53% reduction in overuse, a 45% reduction in severe injury. We followed up with a RCT in our domestic collegiate male cohort. So that was a female study. We wanted to see if this 11 plus was as successful in mitigating injury in the male athlete. So we did a prospective RCT. We had 61 teams involved in this particular study, and we had very similar findings to what SolidGuard found in the female cohort. We had a 46.2% reduction in overall injury in the male collegiate soccer player. We had a 32.8% reduction in time loss due to injuries. So not only were these individuals getting injured less frequently, they were getting, the severity of injury was less. And what was interesting is that when we looked at the odds ratio for days missed, so we had a significant higher number of days missed in the control group. And for each day that was missed in the intervention group, our odds ratio was 1.4. So there were 1.4 days missed in the control group. So again, we had fewer injuries and then lower severity of injury. In the intervention group, we had a higher percentage of no time loss injuries and a lower percent of injuries that were deemed more severe. So those incurring time loss greater than 30 days. One of the more fascinating things, I think, the data points we found in this particular study was the day that the program was actually utilized for the 11 plus, we had significantly fewer days missed when the 11 plus was used. So we're only looking at the intervention group. On the day that the 11 plus was used and injuries did occur, the mean time loss was 6.56 days compared to the days that the 11 plus was not used. The time loss was significantly greater. So we think the implications here are more neurocognitive in nature, that there's some neuropreparedness element to utilizing the 11 plus or any injury prevention program for that matter. On the day of, there's an interesting readiness component. And I think that this is sort of a fascinating data point. So we know the 11 plus is largely successful, and many authors globally have looked at these reductions, and you can see that the mean overall injury rate reduction for the 11 plus is upwards of 53%. So we wanted to look specifically, does the 11 plus decrease the rate of ACL injury in male soccer? And we found, yes, it did indeed. We had a significant decrease in total ACL injury rate by 76%. And this is, again, the male collegiate cohort that I was discussing earlier, between the ages of 18 and 25. We, however, did not see a statistical decrease in contact ACL, but the non-contact ACL injury was statistically significant. So the charge for all of us, I think, when all of us have devoted so much time to injury prevention or ACL injury mitigation, if you will, I think one of the more difficult things that we come up with is the compliance and program fidelity. So we know injuries in sport, they're a very important public health problem. These IPEPs, these injury prevention exercise programs, have been developed over 20, 25, going on 30 years now, and they've been scientifically vetted, but translating it into practice has been difficult. So we want to, obviously we're identifying injury risk, we create the intervention and the implementation, but we need to continue to work on improving implementation, improving compliance, making these programs really easily implemented, not making it onerous for the coaches and the players to utilize on a regular basis so that they can reap the benefit of the injury prevention element. So we know that they work, but what are we actually doing? What biomechanical changes are we making to impart this protective benefit? So we're going to now look at our third step in a reduction risk model here, and we're going to look at biomechanical strength and functional analysis. So part of our my PhD dissertation was to look at what the 11 plus program was actually doing. So we modeled the 6 movement test that was created by Chris Powers, and we looked at this in a pre and post testing protocol. So we used 6 maneuvers: a step down, a drop vertical jump, deceleration, cutting, lateral shuffle, and triple hop. We looked at this in the motion analysis lab, and we did 3 trials of each movement in a preseason and a postseason testing protocol. And so we looked at single leg squat. We know that is a valid tool to screen for neuromuscular deficits associated for knee valgus and lower extremity injury. And these are just 2 examples from 2 individuals in our lab. And you can see some of the form on the bottom is quite problematic. We've got some dynamic valgus, some Trendelenburg, hip internal rotation. And the next step, we looked at triple hop. Sorry for the audio here, but we're looking for, and you can see the difference in control here. We've got increases in vertical ground reaction force, internal rotation on the bottom, Trendelenburg, and a little bit of dynamic valgus. The other two maneuvers we analyzed was deceleration and drop vertical jump. So we wanted to look at sagittal and frontal plane kinematics during these two maneuvers. These were done in both women, female and male soccer players, and basically trying to analyze or identify risk, if that's even possible. I know that's been a controversial subject as of late, but we also wanted to see what the 11+ program was actually changing throughout the course of the season. So when we look at this single leg step down, we found that when we did our regression analysis, we found that there were interactions for group and time for 7 different variables. And we're going to discuss these on the next slide. Interesting findings. So the intervention group, so those individuals that had utilized the 11+ are shown in red. The control group is shown in blue. So we found some promising changes in hip flexion angles. So those individuals who used the 11+ throughout their competitive soccer season, we saw increases in hip flexion angle. We saw favorable changes in the sagittal plane hip moment for the intervention group, and we saw the control going the other way. Decreases in hip internal rotation angle. Interestingly, our control group started at a lower rate, but we saw declines in both the intervention and the control group. And with knee flexion angle, we saw improvements in the intervention group where there was some decline in the control group. For the triple hop, we also found interactions for 7 variables, very similar to what we found in the single leg step down. And the changes that we saw that were favorable were similar to what we found in the single leg step down. So the hip flexion angle maintained higher than the control group throughout the course of the season. And when we looked at hip internal rotation angle, again, similar trend to what we saw in the single leg step down, with the control group starting at a lower angle to begin with, but we did see improvements in the intervention group. The knee flexion moment was interesting. So we saw a promising change or an improvement in knee flexion moment for the intervention group, where in the control we saw some degradation. So when we looked at drop vertical jump, Amy Arundel published this particular paper, and she was looking specifically at the drop vertical jump with relationship to the changes by virtue of utilizing the 11+ program. So she did not find any bilateral changes in frontal or transverse hip motion. However, the 11+, similar to what I found in the single leg step down and the triple hop, it mitigated the changes in knee flexion. So her hypothesis was perhaps that the 11+ is more directly, the benefits are more directly related to the hip, and that's what we found typically. The proximal joint was the more protected benefit, if you will, of the 11+. There was another paper published recently looking at age-related influences in biomechanics by virtue of utilizing the 11+. So this was a paper done using 94 female players with 2 different age cohorts. So there was a younger group, 10 to 12-year-olds, as well as 14 to 18-year-olds. So they had a 15-week season in which the 11+ was used 2 times per week. They looked at a similar biomechanical patterning as we did at the University of Delaware. What they found when they did their baseline analysis is that the 10 to 12-year-olds had increased peak knee valgus angles during all of the activities that they analyzed. And in their post-test analysis, they saw decreases in initial contact and knee valgus angles, as well as their moments. So they saw this increase in pre-contact flexor extensor co-contraction, again, which is beneficial when we look at the risk factors associated with ACL injury. So there was this evidence to support introducing these interventions earlier in development. And that's been our hypothesis all along, is that we basically want to intervene neuromuscular training before these deleterious patterns are very well entrenched, as they hit prepubescence and into pubescence. If we can change these movement patterns at a younger age, or at least provide proper guidance of how these movements should be conducted earlier, before motor plans are well entrenched from a neuromotor neural motor control perspective. I think that's the really, from a clinical intervention perspective, we really should be thinking about these younger athletes in terms of intervening at a younger age. So when we look at the analysis of change, when we look at these 4 movements that we discussed, for the single leg squat, we saw promising changes in increased hip flexion angle, increase in hip flexor moment, decreases in hip internal rotation, and increases in peak knee flexion angle. For triple hop, we saw maintenance of hip flexion, but we saw a decrease in hip flexion within the control group. So that was promising. Decreases in hip adduction moment, decrease in hip internal rotation, and decrease in peak knee flexion. For the drop dump, we saw increases in hip flexion angles, increases in hip flexor moment, decreases in hip internal rotation, increases in peak knee flexion, and decreases in peak knee valgus. And the last activity was for cutting. Again, real promising changes across the board for hip flexion angle and hip flexion moment. And we know hip flexion is a very protective benefit in terms of looking at gluteal posterior chain and hamstring activation, which we know from an ACL injury mitigation perspective is really important. So I think the 11 plus in general, from our particular study and 2 other studies actually that corroborated that evidence, we have shown really promising changes at the hip, which can really impart some benefit biomechanically to the knee joint. So when we look at the 4th step to reduce injury, it's that whole cortical control and athlete readiness to return to play. So one of the things I think orthopedics has been from a very exciting perspective, has really started to incorporate neurology. And I think for too long, we've sort of avoided or sort of ignored the enormous benefit of the cortical control aspect. So we don't want to forget the brain. We want to accurately assess patients' level of confidence and fear. These are all important components to determining readiness to play, but also trying to mitigate risk going forward. So cortical motor control, and I think we'll hear from a speaker later today who's going to discuss this at length, but it's an incredibly important element to consider, and I think often overlooked too often in sports orthopedics. But there are alterations of sensory feedback may underlie the rise in cortical excitability after ACL injury. So after the injury happens, there's this preoccupation, if you will, and there's inability to encompass other outside environmental cues because of this preoccupation. Cortical excitability after the ACL injury remains high, and it dampens our ability to take in extraneous information to navigate and to modify our risk variables. So there's this delay in cortical spinal and interneural efferent output, which delays timing and the intensity of contraction. And this preoccupation can exist or persist rather for upwards of 18 to 24 months. So some of the literature, I know Tim Hewitt published something recently looking at should we be delaying return to sport after ACL injury upwards of 2 years? And I think part of that recommendation, if you will, comes from the cortical motor issues, that this persistence and delay of the cortical excitability and cortical postspinal timing in contraction can persist for some individuals. And that may be why we see this high re-injury rate when we look at secondary ACL. So this is enormously important. I think the 2 years, it gets difficult in the professional atmosphere because that's an enormous delay for an athlete to be out 2 years. But we certainly in the United States have shifted our return to play closer to the 1 year mark, certainly 10 months for sure. And again, taking into consideration that they're meeting all of their functional milestones from a biomechanical perspective, from a strength perspective, from a neuromuscular perspective, and also from a fear and confidence perspective. So looking at your ACL return to sport index, I think Claire Arden and Kate Webster have done enormous work in this regard, so that we've used 2 return to sport criteria from a psychological analysis and fear and confidence perspective for each individual returning to play. And all of these elements are enormously important when we consider return to play for ACL injured individuals. So just to summarize our 4 steps to reduce risk, mechanism of injury, so we can do that. And I think that's been well vetted in the research now, looking at these video analysis studies. The surgical rehab, and I think that's been very well perfected in my estimation. And the prevention efforts, they work. I think the charge remains to increase compliance, increase program fidelity, make it easy for coaches and players to use interventions so they can mitigate their risk systematically and statistically. The biomechanical strength and functional analysis, I think our work continues to be at hand here. I think a lot of what we've learned from a biomechanical perspective can help us go back and perfect the interventions that we've developed over the last 20 years. And the cortical control aspect of ACL injury and return to play guidelines is fascinating to me. I think Dustin Grooms, Ryan Zarzicki, Megan Chapat, they've done amazing work in this regard. And I think that will continue to help guide us from an orthopedic perspective in terms of safely returning individuals back to play. So in summary, we know from a future perspective, we want to analyze if significant injury risk can indeed be detected. I think that's been an interesting data point that we've been looking at. Are these individuals, can we identify risk? Can injury predictive assessment even be feasible? Is that possible? If indeed it is, are the screening tools that we're using, do they have the intended specificity? So are we using the right tools to identify high-risk populations, or can we change and alter this to be even more specific? Continue to address the issue of program fidelity and compliance. Again, I think we have programs that work. They have been statistically vetted, scientifically vetted, but the issue remains that not enough individuals are using them. So I think if we can improve the compliance over the course of the athletic season, we really can allow individuals to play more safely throughout their entire athletic career, and hopefully mitigate the risk of osteoarthritis if we can reduce the risk of the primary ACL injury. And with all of this knowledge, we want to circle back and refine our existing injury prevention protocols that we've designed over the years. So with the biomechanical knowledge and the cortical spinal knowledge, can we go back and fine tune our existing injury prevention protocols to make them even more effective? I think it's been such a challenging time, certainly in our country and around the world, with the pandemic and some of the election chaos that we've recently endured. So I just wanted to sort of end this talk with one of my favorite quotes, like, "So shines a good deed in a weary world." So I just would encourage everyone to be kind and compassionate and continue our efforts as we continue to help athletes around the globe. Thank you so much.